Good afternoon, and today we start cycle of our lectures of dentistry or stomatology. It will be interesting cycle about maxillofacial diseases, disorders, defects, tumors, and traumas. And today the topic of our lecture is dentistry as a science, methods of examination of patients with diseases of the maxillofacial area, caries and its complications, tooth extraction, and complications of tooth extraction. And first of all, let's see what is stomatology or dentistry or oral medicine. It's a medical discipline that studies the structure of the teeth, causes, treatment, and prevention of dental disease, diseases of the tongue, the mucosal membrane of the mouth, jaws, and surrounding tissues of the face and neck. And in task dentistry also includes the development of new materials for filling and prosthetics. Dentistry also encompasses the treatment and correction of malformation of the jaws, misalignment of the teeth, and burst anomalies of the oral cavity, such as a cleft plate. And of course, not only burst anomalies and acquired defects, for example, after tumor extraction or after traumas or other diseases of usually hard tissues of the face. On this slide, you can see different classification or different dental specialties for Russian Federation or Russian-speaking countries and American Dental Association or English-speaking countries. And you can see that they are different. And in Russian Federation, we have only 4 different dental specialties. It's a therapeutical dentistry, surgical dentistry, prosthetic, or prosthodontics, and pediatric dentistry. And let's see, according to the American classification. What for do I give you this different classification? Of course, you won't use Russian Federation classification, but I think that it's most understandable what is the aim of these specialties and what do they do, what can they do, and when can you send a patient for different dental specialties with different pathologies of the tooth, mucosal membrane, gums, hard tissues, soft tissues of the face, bones, and other disorders and diseases. And according to the American Dental Association, first dental specialty, it's dental public health. It's a branch and specialty of the dentistry concerned with the diagnosing, prevention, and control of dental diseases and the promotion of the oral health through organized community efforts, for example, such as research, health promotion, education, and group dental care programs. Endodontics. Concerned with the morphology, physiology, and pathology of the dental pulp and periradicular tissues. And by simple words, endodontics, it's dentists who can treat tooth from inside, from the pulp cavity and root canals. Periodontics. It's concerned with the diagnosis, prevention, and treatment of diseases and conditions of the supporting and surrounding tissues of the teeth or their substitutes, and the maintenance of the health, function, and aesthetic of these structures and tissues. Next, in Russian, it's a surgical dentistry, and previous specialties it was therapeutical dentistry in Russian specialty. Surgical dentistry, and now you are in our lectures in Department of Surgical Dentistry and Maxillofacial and Oral Surgery. And on classes, you'll have most classes or topics according to the maxillofacial surgery or surgical dentistry. And what do we do, or what are our aims? Oral and maxillofacial surgery is concerned with the and includes the diagnosis, surgical and injunctive treatment of disorders, diseases, injuries, and defects involving the functional and aesthetic aspects of the hard and soft tissues of the oral and maxillofacial region, related structures. And of course, here we can talk about inflammatory diseases according to the traumas of bones and soft tissue, skin and oral mucosal membrane, according to the dental oncology, according to the acquired defects in the maxillofacial area. Oral and maxillofacial surgery, it's another part of surgical dentistry in American classification, and this surgery is concerned with the and includes pathology, oral medicine and pathology. It's a branch and specialty of dentistry concerned with the diagnosis, nature, and primarily non-surgical management of oral, maxillofacial, and temporomandibular diseases and disorders, including dental management of patients with medical complications. Oral medicine and oral pathology are two applied components of this specialty. Oral and maxillofacial radiology. Of course, it's a prescription, production, and interpretation of diagnostic images for the diagnosis and management of diseases and disorders of craniofacial complex. And here, the basic knowledge about oral maxillofacial radiology, that it's not only prescription and production, and it's an interpretation, because we have to have a signature of radiologist, oral maxillofacial, who can write that this pathology, for example, it's a fracture or comminuted fracture of the mandible. Of course, oral or surgical dentist knows about it, but it's the aim of radiology. Prosthodontics, it's other branch of dental specialty, and it's the same in the Russian and American or English-speaking countries. Or orthodontics and dentofacial orthopedics is concerned with the supervision, guidance, and correction of the growing or mature dentofacial structures, and diagnosis, prevention, and treatment of any abnormalities associated with these structures. And the last, it's a pediatric dentistry, and as you can see, they are the same, nearly the same in both countries. In Russia, it's only pediatric dentistry, and inside the pediatric dentistry, we have sub specialties, if I can say so. It's a pediatric therapeutic dentistry, pediatric surgery, and pediatric prosthetics, or pediatric orthodontics. In America, it's a pediatric dentistry and orthodontics and dental orthopedics, like different specialties. What do they do? All I've said above, but only for children. And of course, it's concerned with providing primary and comprehensive preventive and therapeutic oral health diagnosis, care, and consultative expertise for infants and children through adolescence, including those of all ages with special care needs. This is the most interesting slide according to the relation between teeth and organs. Our organism is a holistic organism, and if you pay attention, you'll see that every tooth has its relation with particular organs, and even a part of the organs. And holistic medicine is founded on the belief that the entire body is interconnected. In particular, certain teeth are linked to specific organs. The relationship between teeth and organs is so strong that an experienced holistic dentist can determine patient dental history strictly by examining his past and present physical symptoms, and it's possible also to suggest which of the patient's organ might be at risk for certain condition. And for example, the four front teeth are related to the sinus and kidney, while the sharper teeth on the other side connect straight for the eyes and liver, and Chapatis is of course canine. This means that when a tooth suffers damage, the corresponding body organ might suffer as well. And the opposite can also be true. When a body organ suffers, it has the potential to cause pain and suffering in its corresponding tooth or adjacent tissues, ligaments, or periodontal ligaments of the tooth, and even alveolar of these tools. Complete examination in the dentistry. There are following three areas which we have to examine in the patient with different dental or maxillofacial pathologies. It's a general examination. It will be first. Briefly assess the patient's general appearance. Second, it's intraoral head and neck soft tissue examination. Focuses, of course, on the head and neck. And the last part, it's an intraoral examination of soft tissues and hard tissues. Of course, hard tissues, intraoral, we can find teeth. And it's a teeth examination. And let's see according each of these types of examination. General examination. A few words about it. The examination starts as soon as the patient enters the dental operatory. The patient's general appearance may give clues to medical conditions. As the patient enters the room, during history taking, doctor should observe the patient's general appearance, symmetry, gait, and mobility of muscles of the lower jaw. And during the history taking, you have to note any facial asymmetrics, lesions, scars, or any tumors, lumps, or any deformities, or something which is not normal. It's according to the general examination. Extraoral examination, asymmetries. Of course, it's a first. Asymmetries of the head and neck are assessed by standing directly in front of the patient. You should compare one side of the head and neck to the other. Most people are not completely symmetrical, but significant asymmetries should be noted and the cause obtained from the patient if known. Examples of asymmetries are previous surgeries, nerve paralysis from severe stroke or tumors, infections, some traumas, and a lot of different types or causes of asymmetry, and you have to note it and to know about the causes of this asymmetry. Next, it's lymph node examination. Lymph nodes in the head and neck area should be palpated gently to look for tenderness or enlargement. Normal lymph nodes are either not palpable, or you may feel a lymph node that is inside and shape of a small pear or lentil. These are mobile and non-tender. Abnormal lymph nodes are generally larger, fixed, and may be tender. Tenderness of the lymph node generally indicates inflammation or drainage of infection. Cancer metastasis to a lymph node is often fixed, non-tender, firm enlargement. Lymphoma is another possible cause of non-tender enlargement of lymph nodes of the neck, and usually, if it's pathological or neoplastic enlargement of lymph nodes, it's not enlargement of one lymph nodes, it's enlargement of group of lymph nodes, and of course you have to assess it and do other types of examination, not only palpation. What locations of lymph nodes we should palpate? It's periauricular, postauricular, suboccipital, submandibular, submental, and all of these groups of lymph nodes you can see on the slide, on the picture inside the slide, and cervical, supraclavicular lymph nodes. These all groups you should palpate and assess. Next, it's a temporal mandibular joint examination. What can be examined? Limited temporomandibular joint examination may be done at the initial dental appointment. And how can we do it? You have to put fingers or fingertips over the temporomandibular joint with dental pressure. Not any tenderness, swelling, or redness expressed. Then you have to ask the patient to open and close slowly the mouth several times. You can ask the patient not only open and close mouth, but to ask him move the mandible from side to side in the open position. And in this examination, you have to record any tenderness, pain, maybe clicking, crepitus, deviation from one side to the other, or limited openings. Major salivary glands should be palpated and milked to assess salivary gland duct orifice patency and salivary flow, and to evaluate the quality of saliva. For example, frothy versus cirrhosis, or maybe prudent or even absence of saliva. And you have to note intraoral soft tissue examination. And as you remember, intraoral examination we can divide into two big groups. It's the intraoral soft tissue examination and intraoral teeth examination. And according to the soft tissue examination, it's important to record if the soft tissue is within normal limits or not. If there is any abnormality, further details are known, such as a type of abnormality, for example, polyp, buccal, ulcer, size of this abnormality. It's a measure exact size with a periprobal ruler, color, location, surface texture, for example, smooth, papillary, lobulated, and consistency, soft from fluctuant. Intraoral soft tissue examination, we begin from the lips, and yes, lips, it's due to the intraoral examination, then buccal mucosa and vestibular mucosa. What is the different and what is the vestibular mucosa? It's a part of soft tissues of the oral cavity between lips and teeth. It's a vestibular part of mucosa. Oropharynx, tongue, floor of the mouth, and floor of the mouth, it's a space under the tongue, and the gingiva and alveolar mucosa. The maxilla and mandibles should be palpated to check for enlargement such as the exostosis or tori. This examination may also reveal tenderness that could be a result of infection or inflammation. It's important to record the finding of the extraoral and the intraoral examination. This is normally done during the examination process. There are many different methods of recording results, including checklist and free text. And on this slide, you can see different types of pathologies of intraoral soft tissue examination, which we can find, yes, during the examination. And of course, all of these should be noted and recorded. And the next, it's a teeth examination. And of course, when you say that you have a dentistry cycle, or stomatology cycle, everyone should think about or will think about teeth. How can we examine the teeth? We have to note or assess, first of all, oral hygiene status. Plaque or tartar, and according to plaque and tartar, according to the difference and role in the formation of caries and other dental diseases. We'll talk about it a little bit later. Then we have to assess the teeth present, or any prosthesis should be recorded. Previous treatments of the teeth, material conditions, the status of restoration, for example, restoration fractures or failures or oval extensions, Then you should note the presence and the surface of location of the caries or maybe non-caries lesions, discoloration of hard tissues of the tooth, crowding, rotation, space loss, eruption status, class of malocclusion, and periodontal status. Bleeding, a recession of gums, and increased mobility. Or here, in sometimes, if we have, for example, X-ray or CT, we can add not only a recession of the gums, but recession of the bone or alveolar bone. The dentist or dental hygienist uses instruments such as the mouth mirror, periodontal probe, and explorer to examine the teeth. Every tooth is checked for cavity. The conditions and positions of the teeth, both erupted and impacted, are noted. Previous treatments such as the crowns and other restoration are evaluated. About all of these points are said. The dentist evaluates the gingival gum tissue for periodontal disease. A periodontal probe measures the depth of the pocket around each tooth. If the gums are healthy, the pocket will be less than 3 millimeters deep. Pockets for 4 millimeters or more indicate periodontal disease. The deeper the pocket, the greater the chance for tooth loss unless treatment is begun. And on this slide, you can see different pathologies of hard tissues of the tooth, and you can see crown caries, for example, in the upper picture. In the lower picture, in the left, you can see incorrect position or dystopia of canine, and it's usual in most of dystopias. Diastema, a space or gap between two teeth. Recession of gum and bone, it's a periodontal disease. And, for example, root caries. In the last picture, you can see. All this should be noted. And the next very interesting question, according to the teeth numbering system. How can we note all these findings in the checklist? In order to understand in what tooth we can find what type of disease, in what part of the tooth this disease, we have such teeth numbering system. And the most widespread teeth numbering system, it's a Federation Dental International Numbering System or FDI system. You can see this system on the slide. All teeth are divided into 4 quadrants. It's understandable that upper jaw is divided into 2 quadrants, upper right and upper left, and the same lower or mandible, teeth of the mandible are divided into lower right quadrant and lower left quadrant in a central line between 2 central incisors. And we'll start this numbering system from central upper right incisor. And you can see that the number of these tooths is 11. Lateral incisor 12. Canine of the upper right side is 13. 14 and 15, it's a premolars, first and second premolar, and 16, 17, and 18, it's a molars. And it's understandable that 16, it's an upper right first molar, 17, upper right second molar, and 18, it's an upper right wisdom tooth. The same, we start our numbering from upper left side, and we start from 21st. Central incisor of the upper left side, number of this incisor will be 21st. 22nd, lateral incisor, canine. Only on the upper left side, it's a number of 23. 24, 25, it's a premolars, and the same 26, 27, and 28, it's a molars. And then we go to the lower jaw and the left side. It will be like a circle. We start from the right side, patient's right side, and then go to the upper left side, then lower left side, and lower right side. And it's understandable that the last number of the tooth, it will be lower right wisdom tooth, and its number will be 48. And here, pay attention. Now we are talking not about amount of the teeth inside the mouth. It's not supernumerary teeth in the mouth. It's not pathology. It's only number of the teeth from 11 till 48. And of course, it's very useful and for practice to know what particular tooth, for example, we have to do X-ray, or what particular tooth we have to extract, or what particular tooth was opened pulp cavity and was, for example, the pulp was extirpated. And according to this teeth numbering system, we can understand who is it after death. The next teeth numbering system is a Palmar notation method, and you can see that the same, we have to divide all teeth into 4 quadrants, the same as the previous teeth numbering system, but here we have to use such an angles according to the maxillary teeth. This angle is opened up, and according to the mandibular tooth or noted mandibular teeth, this angle is open to the or the down position. Maxillary right is open to the right side angle and left to the left side. I think it's understandable and not difficult. And inside this angle, we have to write the number of the teeth. For example, you can see, for example, this angle, and inside this angle, let it be maxillary right angle, and inside it you'll see 7, number 7. It's understandable that it's a 7th tooth from the central position of the maxillary right side, and it's understandable that it's a 17th teeth, 17 tooth for FDI system numbering position. Other types of teeth numbering system, it's by letters. It's not convenient for doctors, and it's not widespread, but you have known about it that there is such a system. And on the right side of the slide you can see other teeth numbering system, but you can see that there are not 32 teeth but only 20, and it's understandable that it's a milk teeth, a deciduous teeth. And this numbering system is the same as the DI system, but only for milk teeth, and we'll start from the upper right central incisor, and its number will be 51 till 55, left upper side from 61 to 65, and then lower left side 71 to 75, and 81 85, it's a lower right side of the milk teeth. And of course, if you are attentive, you'll have a question. When we'll have changeable occlusion or teeth inside the mouth, if it's a child of 12 or 13 years old, for example, it will be a girl, and she'll has a inside of the mouth permanent and deciduous teeth, and you have to know that this one is permanent. In its number will be, for example, 16 or 11 or 12, and for example, canine is a deciduous, a milk, and its number will be 53rd. I hope it's understandable. Unfortunately, we have some problems, and if you have some questions, you may ask them in the class. And the next question for today's lectures, it's the types of the tooth. We said about this numbering system, but what types of the tooth do we have? I hope and even I'm sure that you know about these types of the tooth and a few words only about. According to the crown parts, we can see that there are different types of the tooth: central incisors, lateral incisors, or incisors, then canines, then premolars and molars. And let's see on anatomical structure of the tooth. Incisors are used for cutting and biting. Canines are used for gripping and as well as the premolars, and molars are used for bringing. Every tooth consists of crown, root, and neck, and it's an anatomical structure of the tooth. Crown. Crown is a visible part of the tooth in the mouth, while the root is hidden beneath the gingiva and alveolar bone in normal or healthy tooth. It has a pure white or yellow color depending on the thickness of enamel, the age of the patient, their oral hygiene, and lifestyle choices. The enamel is an outer layer of the tooth and it's extremely hard and durable. Underneath this third exterior layers a second soft layer that is slightly darker in color and it's known like a dentin. This is a capsule that separates from the hard outer tissues from the soft and fragile pulp cavity, which is most inner layer of the tooth and contains the blood vessels and nerves of the tooth. The enamel and dentin must be intact in order for the tooth to stay alive and healthy. For once any bacteria enters the pulp chamber, the damage is irreversible. Root. The roots of the teeth, whether they are single or multiple, is the number of each of hand, two, or three previous mentioned layers in their make. The pulp chamber continues down from the crown into the roots and finishes at the apex of the root, where there is an opening which allows the structure of the pulp chamber to exit and enter the pulp cavity inside the tooth. This is also surrounded by the dentin that finishes just before the apex, where it's surrounded by not by enamel but by cementum. Cementum is histologically different from enamel, but it acts as its equivalent from just below the gingival line and covers the entire root of the tooth. The meeting point between enamel of the crown part, yes, which covers the crown part of the tooth, and the cementum, which covers superficially only root part of the tooth, is known as cemento-enamel junction or neck of the root. And on this slide we can see these differences. And let's see once more. Crown part, it's a visible part of the root, and different different teeth have different crown parts by anatomical structure. But all of the teeth have histologically the same tissues. Crown part superficially covered with enamel. It's the hardest tissue of the tooth and of the organism. Under the enamel, in the crown part, we can find dentin. And dentin we can find in the crown part and in the root part too. But superficially, in the root part is covered with cementum, the same as the crown part is covered with enamel. And let's see the layer of the root part. It's a cementum, then dentin, and pulp or root canals with pulp inside of it. And in the end of the root, we can see the orifice or opening, which allows blood vessels, lymphatic vessels, and nerves enters and exit pulp cavity inside the tooth. Those teeth which have a live pulp, it's a live tooth or a live teeth. tooth without pulp or with dead pulp or with irreversible pulpitis or with root canal filling, it's a dead tooth. And let's talk about different lab investigations in dentistry. Of course, there are a lot of different lab investigations which we can use in different sections or specialties of the dentistry in order to put a diagnosis or make a differential diagnosis or even in order to treat our patient. And what are they? First of all, and most widespread investigation, it's of course radiographs or X-ray. Radiographs of the teeth and bone are one of the most valuable diagnostic tools, and the dentist has to evaluate structures that cannot be seen by clinical examination. Dental X-ray are divided into two main categories, intraoral and extraoral. With intraoral X-rays, the X-ray film is inside the mouth, and with extraoral X-ray, the film is outside of the mouth. The various types of intraoral X-ray should be different aspects of the teeth, and we can find, for example, cavities, different cavities and carious cavities. Look at the tooth roots, check the health of the bony area around the tooth, see the status of developing teeth, otherwise monitor good tooth health, to see any lines of fracture, impacted tooth, and a lot of different pathologies. Tumors inside the jaws, any tumor-like lesions inside the jaw we can see on different radiographical investigations. Intraoral or extraoral radiographs are made with the film outside of the mouth, and this can be considered by the big picture X-rays. They show teeth, but they also provide information of the jaw and skull. Extraoral radiographs are used to keep the track of the growth and development, to look the status of impacted teeth, examine the relationship between teeth and jaws, examine the bones of the face. Extraoral X-rays are less detailed than intraoral X-rays usually, but in sometimes intraoral X-rays can be excellent and essential for the patient, for the dentist. For this reason, they are usually not used for detecting cavities. It's according to the extraoral X-rays or flaws in individual teeth. Different types of X-rays. It's a periapical X-ray, include the entire length of the tooth, including the root and surrounding tissues. Between X-ray shows the crowns of maxillary and mandibular teeth. Occlusal shows entire maxillary or mandibular arch on one larger film. Panoramic X-ray shows the entire mouth on a single X-ray. They include all teeth of the both upper and lower jaw. And usually panoramic X-ray we call as OPTG or orthopantomograph, and of course it's very useful for dentists in order to examine not only the tooth or teeth structures, but we can see sinuses, we can see temporomandibular joint and hard tissues or bones of the face, maxilla and mandible, and sometimes we can see zygomatic bone and arch. Cephalometric projections are X-ray taken of the entire side of the head. They are used to look at the teeth in relation to the jaw and the person's profile. Orthodontics use cephalometric projection to determine the best type of orthodontic treatment. Combined computed tomography or CT provides three-dimensional images. I'm sure that you understand it. And next, slide shows us these different types of X-ray. You can see periapical, intraproximal, panoramic X-ray, occlusional, cephalometric, and cone beam CT. And you can see different structures which we can see or which we can examine to put a diagnosis, or maybe to make control X-ray in order to assess previous treatment. And all this part of the lecture was about dental investigations and assessment of the patient. And now let's talk about dental caries. Two main factors contribute to tooth decay: bacteria in the mouth and the diet high in sugar and starch. There are over 500 different types of bacteria that are normally present in the mouth. These bacteria combine with the food and saliva to form a sticky substance called plaque that attach the teeth. Foods rich in the starch add to the thickness of the plaque, which begins to get hard if it remains on the teeth after a couple of days and turns into tartar or calculus. Bacteria in the plaque convert sugar into acid that dissolves the tooth structure, causing holes or cavities. Because of these two contributing factors, dental caries have been described as a dentofacial disease. Factors that affect tooth decay are following, and you can see them on this picture in the slide. Sorry, it's different. It's a tooth size and shape. For example, small teeth with numerous deep pits and grooves will be more vulnerable to cavity formation than the larger teeth, with fewer and shallower grooves. The grooves and pits provide areas for plaque to build up and are difficult to brush thoroughly. Thickness of the enamel. Enamel is the tooth's main defense against cavities, so the more of it a person has, the longer it will take for a cavity to break through the inside of the tooth. Tooth position and bite. Crooked, overlapped teeth provide more areas for plaque to accumulate and they are harder to keep clean. Many problems can occur if the bite is poorly aligned. Poor alignment of the bite can cause the enamel of certain teeth to wear down rapidly, leaving soft dentin exposed. And the last one, it's tooth eruption time and sequence. People who get their permanent teeth early in the life are at great risk for cavities because oral hygiene practices may not be developed yet, and the growth of the bones of the organism needs calcium, and of course, caries can occur more early. Poor oral hygiene. Of course, it's one of the widespread causes of the caries, of the dental caries. Not brushing teeth regularly allows plaque to build up and attack the tooth enamel. Here I'll say a few words about oral hygiene. Of course, we have to brush our teeth twice a day, and our patients and we have to use dental flosses or flossing in order to remove food residue and plaque from proximal surfaces, the surfaces between the teeth. And if these proximal surfaces or teeth stands close near one to another, it's difficult to clean with a brush. Only with the brush, and we have to use flosses. And in the most cases of proximal caries, when caries starts in this surface between teeth, are invisible, and it's very difficult to evaluate these surfaces, and these caries can lead to the pulpitis. Symptoms of pulpitis are reversible then irreversible, and our patient can, as outcome, lose the teeth. Other causes of dental caries, it's a dry mouth, it's food. What about food? A few words. There is a lot of different foods which can lead to the caries formation or cariogenic foods. Carbohydrates inside the food and sugar remains on the teeth until the patient will brush it. Even after brushing, the patient may be able to remove all food particles or carbohydrates from the teeth. Food that tends to cling to the young teeth can increase the risk from the tooth cavity. Be sure to brush the teeth regularly, especially after drinking milk or soda or after eating dried food, dried cereal, hard candy, caramel, and other sweets. Usually we say to our children, don't eat sweets or chocolate, and don't drink a lot of cola and other drinks with gases. And of course the last course, it's medical problems. There are different medical problems which can lead to the caries formation, which can lead to the other dental diseases and periodontal diseases. And of course, most widespread, it's diabetes. And maybe malignant tumors, cancer, and other immunodeficiency states. What are the signs and symptoms of cavities? Now, when a cavity advances deep into the tooth, it may produce increased sensitivity to the foods that are cold, hot, or sweet. And of course, not only foods, the drinks too. But not all cavities will cause a toothache. If they are small or progressing slowly, they may only be detected by a dentist before they cause a pain. Cavities on the front of the teeth are earliest for the person to see, and they will be visible as the light dark brown spot. Generally, light brown represents as a fast-growing cavity and dark brown represents a slow-growing cavity. If the cavity gets large enough, part of the affected tooth may break off and leave a hole. A dentist can detect a cavity by using a sharp instrument to feel the tooth structure that has been softened by tooth decay. If a cavity forms in between the teeth or in the proximal surface, as I said, it may only be visible on X-ray. And what about dental caries classification? Of course, there are a lot of different classification, and most of them were used for stomatological students. But you have to know about main classification, and I think it's interesting and essential for each person and for each student and for each alive person. Because dental caries is most widespread dental pathology in the world. Classification based on the tissue involvement. Depending on which teeth affected are distinguished enamel caries, dental caries, and caries of cementum or cementum caries. And here you can see that caries, according to this classification, can be only on hard tissues of the tooth, enamel, dentin, and cementum. And sorry, this is there is a mistake in the cementum. Based on progression, acute caries, chronic caries, and arrested caries. According to these acute caries, it's rapid progress involving a large number of the teeth. And these lesions are lighter colored than the other types, being light brown or gray. And usually we can see only a hole or a cavity inside the tooth. And if it's without any discoloration or darkness of the hard tissues of the tooth, mostly it's acute caries. Chronic caries, of course, it lasts or long-standing teeth lesions. or hard tissues lesion, and it affects a few number of the teeth, and they are smaller than acute caries. Pain is not a common feature because of protection afforded to the pulp by secondary dentin. And of course, it's understandable that if it's acute, it will progress more fast, and if it's a chronic caries, progression will be more slowly or slow progression. And with this slow progression in the tissues, in the hard tissues of the tooth, we'll find histologically process of demineralization is a process of caries, and process of remineralization as a as a process opposite for demineralization, and the organism try to heal, try to restore the hard tissues of the tooth and the structures of the tooth. And of course, it's impossible but to build up secondary dentin to protect the pulp from bacteria and from this lesion. It's possible. And according to this secondary dentin, we can find the discoloration or dark color of hard tissues of the tooth according to the chronic caries. And here on these photos or pictures, you can see difference, visible difference between acute process and chronic process. And we can diagnose it only by visual examination. The classification based on anatomical side. Occlusional or pit and fissure caries or crown part of the teeth caries, and smooth surface caries, for example, proximal and cervical caries of incisors, and root caries. Based on virginity of lesion, initial or primary caries is one in which the lesion constitutes the initial attack on the tooth surface, and recurrent secondary caries is observed around the edges and are under the restoration. And in Russian, we have in this classification the part. It's atypical caries. It's a caries which is found in the dead tooth or tooth without pulp. And this is the main classification of caries based on tissue involvement or deepness of the process. And you can see the next parts of this classification: initial caries or reversible type. It's a lesion of enamel in which the surface layer remains intact. It happens in two stages: stage of white spot or progressive demineralization, and stage age spot or suspended demineralization. On both these stages, and only this part of classification or this type of caries, it's a reversible type. And what does it mean? It's only demineralization of enamel. We can see, we won't find in histological examination destruction of enamel or destruction of hard tissues of the tooth. It's only process of demineralization. And if it's a demineralization, it's understandable that we can do something or use special materials in order to activate opposite process of remineralization, and only this stage can be reversible. I hope it's understandable. All other stages are irreversible. What does it mean? In all other stages of the caries, you will find destruction of hard tissues of the tooth, and of course, it's we can't do remineralization, or we can't affect on this destruction, and we have to do caries treatment. And let's see other parts of this classification. Superficial caries. It's a surface caries is defect within the enamel. Or if it's a root caries, the defect will be within the cementum. It will be root caries. But both of these caries will be superficial. Defect is inside the enamel. moderate or middle caries, defect extends beyond the boundaries of the enamel-dentin junction. It goes deeper to the dentin, and in some books you'll find, or in some literature you'll find, that we can divide the dentin into two parts. Upper part, which is nearly to the enamel or enamel dental junction, it will be middle caries or moderate caries. And in that part of the dentin which is deeper or near to the pulp, it will be deep caries. Or deep caries, it's a destruction of significant portion of the dentin with the formation of the cavity, the bottom of which is separated from the cavity by only a thin layer. And the last part of this classification is a deep complicated caries. Complicated by what? By pulpitis, of course, or inflammation of the pulp, and periodontitis or periapical periodontitis. It will be true for English literature classification. What according to the symptoms of the caries? And you can see on these slides, and listen my explanation. First, initial caries or stage of the spot. According to the symptoms, it can be symptomless at all, or maybe in sometimes patient will complain of some sensitivity of the tooth, maybe after eating some specific foods like extremely spicy or something else. Usually it's symptomless because there are no any destruction, it's only remineralization, which we can see by such white spots without shining on the smooth surface of the tooth. The next, it's a superficial caries, and you can see it on the next picture. As you remember, it's a destruction of enamel. Enamel, it's a hard tissues of the tooth. It's a hydroxyapatite of the calcium and phosphate. And of course, it's understandable that there is no any nerves inside the enamel, and of course, this lesion or this destruction can lead to some pain. But if it's a middle caries and the process of caries is deeper and it's inside the dentin, or it affects the superficial part of the dentin, inside the dentin we have canals with a small nerves, and of course in the middle caries, our patient can claim on some pain. It will be acute, sharp pain, short pain by the duration, and the main characteristic of caries pain is a pain due to some irritants. Patient will say you that when I drink some hot tea or hot coffee or cold Coke, I can feel sharp, localized, how to say, extremely painful feeling on particularly this tooth. And when I wash my mouth or swallow this tea, or for example maybe some sweet candies, or usually it's chewing candies, can cause such a pain, or if it's a proximal cavity, when patient eat some chocolate, it can get inside the cavity and irritate these nerve endings inside the dentin and can cause pain. But after washing the mouth, the pain reduce at all, immediately reduce. And if it's a deep caries, of course, the deepness or depth of the cavity is near to the pulp, and the irritation will be more sharper. Pain will be like a throbbing pain, acute pain, but it will be localized and it will be short by the duration, even if it's a deep caries. And what according to the treatment of the dental caries? Here you can see that there are two ways of treatment. First, only for stage of spot, and pay attention. Once more, stage of spot only. We can do professional brushing with special instrument and then apply topical fluoride calcium treatment of the smooth surface on the surface of this tooth with a stage of with a spot on it, and it will activate the process of remineralization and caries or treatment will be done. In all other stages, from initial till the deep, it's a drilling and dental filling. Of course, we have different techniques or methods of drilling. We have different bores for drilling. We have a lot of different drillings for filling different parts of the tooth, different teeth. For example, incisors, it's aesthetic units, and molars, these materials for filling should be strength enough in order to prevent a fracture or some other failures of our filling due to the pressure on the molars and premolars. And if it's a deep caries, we can use special treatment linings or treatment filling, and then above this treatment filling, we can do dental filling in order to restore the crown part of the teeth and restore the function of this teeth. And of course, the very important or essential question of dental caries, it's a prevention of it, because of course it's more easily to prevent than treat. What according to the prevention? Toothbrushing, of course, twice a day, and every patient should be noted that there are a lot of different types of toothbrush, and every patient should choose those toothbrush which is most useful for his hard tissues of the tooth, for his enamel and gums. Mouth rinsing, dental floss using, topical fluoride application, and there are different fluoride application. They can be used in dental cabinet or dental by dentist or at home. Pit and Fisher sealants, so they can be used usually for children after tooth eruption in a few weeks or few months after eruption of the tooth. And nutrition and diet, of course. Don't eat sweets, and if you eat it, you have to brush and use all prevention methods for dental caries. The next question is a pulpitis. As I said, the pulpitis, it's a complication of caries. And what according to the condition or according to the term of this pulpitis? It's understandable that it's inflammation of the pulp. Pulp, it's a soft tissue of the tooth. And pulpitis, it's a condition that causes painful inflammation of dental pulp. It can occur in one or more teeth and is caused by bacteria that invade the tooth pulp, causing it to swell. And there are several forms of pulpitis. It's an open pulpitis and closed pulpitis. Open pulpitis is usually chronic pulpitis, and other classification is acute and chronic. You can see this classification on this slide, and acute pulpitis can be subdivided into reversible and irreversible. Reversible is hyperemia of the pulp, and irreversible it's a necrosis of pulp. And chronic pulpitis, it's usually closed and opened. And this classification can be added to the acute pulpitis. Open pulpitis usually hyperplastic pulpitis. And what does it mean, open pulpitis? Pulp chamber may be or should be open due to the destruction of the part of the crown and communicate with the oral cavity. And closed, it's understandable, pulp chamber is not damaged. Part of the pulp becomes quickly destroyed, resulting in acute inflammatory reaction. Reversible pulpitis refers to instances where the inflammation is mild and the tooth pulp remains healthy enough to save. Irreversible pulpitis occurs when inflammation and other symptoms such as pain are severe and the pulp cannot be saved. Irreversible pulpitis may lead to a type of infection called a periapical abscess or periapical periodontitis. This infection development of the root of the tooth where it causes a pocket of the pus to form in the periapical tissues. If not treated, this infection can spread to other parts of the body such as sinuses, jaw, or even brain. And let's see what are the symptoms and signs of reversible and irreversible pulpitis. Reversible pulpitis, mild to moderate pain, reaction to the physical irritation, usually called as sweet. It's a strong, sharp pain, but this pain will be longer than due to the caries. Brief duration, and here, yes, I wrote about it. When the stimulus is removed, the pain causes within 1 or 2 seconds, maybe 5 seconds. But if it's a caries pain, after removing the stimulus, pain reduced immediately. These usually show deep caries or restoration with defective margins. Reversible pulpitis, if allowed to progress, can lead to the irreversible pulpitis. And what about irreversible pulpitis? Spontaneous pain typically at night. And here the same, pay attention according to the characteristic of the pain, because it's a main characteristic of differentiation diagnosing according to the reversible and irreversible pulpitis and according to the caries and pulpitis. And pulpitis, for example, in periodontitis. If it's a irreversible pulpitis, usually it's a spontaneous pain, typically at night, due to the working of parasympathetic nerve system. Pain lingers minutes after the stimulus is removed. Usually stimulus, it's a heat or less frequently cold, and may progress and irradiate. Difficulty locating the tooth from which the pain originates, and usually patients even can't understand on which jaw. They can show only a side of the pain. They can say that I can feel acute pain, it's awful pain in the left side of the face, or and even I can't understand. And sometimes it seems that it's upper jaw tooth, and sometimes I think that it's lower jaw. I can't understand. When pulp necrosis is complete, the pulp no longer responds to a hot or cold but often responds to percussion. That means that the pulp is dead and no pain according to any stimulants. And inflammation or infection extend the periapical tissue can cause periapical disease. It's understandable too. And here on this slide you can see open hyperplastic pulpitis. It's a chronic pulpitis because it takes time to proliferate or to grow this granulation tissue from the pulp chamber. And of course we have to treat it immediately. Diagnosis. First of all, it's a clinical evaluation, history and physical examination. Sometimes we can do X-ray, help to determine whether the inflammation has extended beyond the tooth apex and help exclude other conditions. X-ray findings, we can find only caries. We can't put a diagnosis on based on X-ray film, for example. On the clinical evaluation and patient complaints, can give us a basis to put a diagnosis. Treatment, the same, drilling and filling for irreversible pulpitis, and we can put a special treatment material on the pulp horns. If it's an irreversible pulpitis, we have to extract the pulp, then to do root canal treatment, and then filling, root canal filling, and filling of the crown part of the tooth. And if needed, antibiotics can be prescribed. Here on these pictures, you can see root canal treatment, stages of the root canal treatment. First of all, of course, it's a pulp extraction, and on the picture C, you can see extirpated pulp. It's soft tissue, it's a part of the nerve, and we have extracted from the root canals and crown part of the pulp. Then we have two antiseptics of the root canals to stop bleeding, then soften the root canals and be sure that there is no any remains of the antiseptics and wax inside the root canal, and then we can do root canal filling. And after our filling, we can do X-ray or control X-ray in order to be sure that we fill the canal till the apex. And the next part of our lecture, it's a periapical periodontitis. There are different types of periodontitis, and now we'll talk about only periapical periodontitis, and usually it's a chronic process. But of course, they can be acute, or it can be acute. And according to the classification, let's start from this slide. Clinical morphological forms, it's acute or serous and purulent periodontitis, periapical, and chronic can be granulomatous, granulated, and fibrous. And according to the etiology, it can be infectious and non-infectious. Infectious, it's understandable. Infectious, the cause of this periodontitis is a streptococci, staphylococci, or other bacteria, virus, and fungus which goes or which spread from the caries cavity, from the pulp chamber and root canals outside in the periapical tissues from the apex foramen, and can cause periapical periodontitis. According to the non-infectious periapical periodontitis, they can be traumatic, toxic, including iatrogenic, for example, injection of the medicines with injuries, dangers, bad habits, and occupational diseases. According to the clinical manifestations or clinical features of periapical periodontitis, they can be asymptomatic and symptomatic. As you might guess, asymptomatic apical periodontitis doesn't produce any clinical signs or symptoms, and usually it's a chronic periodontitis. However, this condition produces inflammation of the tissue surrounding the teeth and can cause a destruction of the tissues. An American Dental Association notes asymptomatic apical periodontitis was one referred to as the chronic periapical periodontitis, and it's usually ongoing at the development graduate. The other type of apical periodontitis is symptomatic. This type of inflammation causes pain and discomfort when the person bites down on when a dentist taps on the surrounding teeth or percussion. Symptomatic apical periodontitis is usually acute, meaning meaning it comes on suddenly and gets worse quickly, but it can also be as exacerbation of chronic. And here let's have a few words about differentiation diagnostic between exacerbation of chronic and acute. As I said earlier, if it's a chronic periapical periodontitis, we'll see changes on X-ray. If it's acute periapical periodontitis, it's not enough time passes from the beginning of the process, and our patient will have a clinical manifestation of this disease. And main manifestation is a pain during biting or chewing on this tooth, and patient will claim that he can't eat. And even a swelling of soft tissues of the gingiva of this area or nearby the affected tooth can be assessed, and without any X-ray findings. It will be acute. But if you see a patient will claim on acute pain, but on X-ray you find any destruction, that will be exacerbation of chronic periapical periodontitis. According to the treatment, you can see on this slide, it can be conservative and surgical. Conservative treatment, it's endodontic, and surgical, it's by, for example, resection of the apex of the root, hemisection, or other surgical procedures which can lead to the removing of infection of periapical tissues. Tooth extraction. For the following finding, there is no sensible alternative treatment option. Teeth severely damaged by caries, retained roots. Teeth severely damaged by periodontal disease. Teeth by with periapical infection that can neither be preserved endodontically nor by surgery, and have caused an extensive inflammation, for example, maxillary sinus or soft tissue inflammation or cyst. Teeth damaged by trauma, multiple fractures, longitudinal fractures, extensive bony defect in the periodontal region. In case of crowding or impeded eruption, milk teeth and permanent teeth should be extracted for orthodontic reasons. And during prosthodontic treatment, in order to maintain normal occlusion, elongated or heavily tilted teeth, particularly with previous contacts. And during tumor surgery, teeth located within the area of the tumor. There was a then let's talk about local indications for tooth extraction, and you can see that there are a lot of different local indications, but most widespread it's a tooth in a fracture cleft, overrupted tooth without antagonist, prior to extensive prosthodontic treatment, in situation where it's unclear if the tooth should be preserved prior to the high-quality conservative and prosthodontic treatment, pericoronitis, to prevent follicular cyst around impeded teeth, and if there is a risk of root resorption of adjacent teeth due to a direct contact with the impacted teeth, resorption of alveolar bone due to the repeated infection around the partially impacted teeth, teeth with apical changes after root treatment, prevention of neurologic pain, preventive measures against the relapse due to crowding of anterior teeth. And of course, according to the indication, it's understandable when we can save the tooth even severely damaged with caries, if it's possible by special orthodontics constructions or prosthetic teeth or artificial teeth, we have to save it. Extraction, it's a radical procedure which can be done only if conservative or surgical treatment is unforceable or ineffective. Contraindications. Contraindications for an extraction are usually temporary and concern the general medical suitability of the patient for surgery. For example, bleeding tendency, immunosuppression, conditions following the myocardial infarction less than 6 months, or local surgical disorders, for example, non-odontogenic abscess or tumor. The tooth or teeth should then be extracted after adequate pre-treatment and, if necessary, under what are referred to as risk conditions. Taking acute inflammation into the consideration during radiation and chemotherapy, anticoagulation, hemorrhagic diathesis or hemophilia, acute phases of myocardial infarction, acute leukocytosis and granulocytosis, and severe cardiac insufficiency. How can we extract the tooth? Simple extraction and surgical extraction. For simple extraction, we need next instruments. And we can do simple extraction when the tooth is erupted and visible inside the mouth. What can we use as instrument for simple tooth extraction? It's a dental forceps and dental elevators. Dental forceps, you can see that they are different for upper and lower jaw and even for different tooths and roots. And in a practice or in the classes, we'll talk about it and we'll show you different dental forceps and elevators. Elevators can be used usually for extraction of roots or tooth without crown part, because they can be easily put between the crown or between root and alveolar bone and extracted. Root can be extracted. And that part of tooth extraction, it's a surgical extraction. Involve the removal of the tooth that cannot be easily assessed, for example, because they have broken under the gum line, or because they have not erupted fully, or they are impacted. And what are the stages or steps of tooth extraction? Dental step and alveolar step. Dental step, it's a first of dental step, it's a dental anesthesia. We have to do local anesthesia with different anesthetics. And after anesthesia, we have to do syndesmotomy. It's a surgical division of a ligament of the tooth. Then application of forceps, slip along the wound with the forceps, fixation forceps, dislocation of the tooth. All the stages are dental step. And the alveolar step, it's a tooth extraction and revision of alveolar. Oh, sorry, why tooth extraction? Tooth extraction is a dental step too. Revision of alveolar. What have we to do in this step, alveolar step? We have to to assess alveolar parts. We have to be sure that they are not sharp, and broken parts of alveolar should be removed. We have to be sure that we didn't stay inside the alveolar any granulation tissues or cysts, because in the future, if they stayed inside the alveolar after wound healing process, our patient will come to us with residual cyst or cyst which is inside the jaw, but tooth was extracted earlier. And here you can see dental and alveolar step, and it's a picture, it's a revision of alveolar. And then we have to ask the patient or prescribe semi-liquid diet for first day only, and don't wash the mouth or use mouthwashes for 24 hours in order to save formation of the blood clot inside the alveolar as a substance for wound healing. According to the complications of hemorrhoids, of course, it can be hemorrhage. In most cases, this is due to the poor inspection and debridement of the tooth socket, leaving a granuloma or cyst in place, and they can bleed heavily, or after local anesthetics. Alveolitis due to the anoxia of the bone or an alveolar sequestration left in a place or broken part of the alveolar and producing severe lancing pain 2 or 3 days after the intervention. We have to clean the socket or alveolar, then introduce a wig with a dental violet and leave for at least 3 or 4 days, then prescribe analgesics and antibiotics in case of infection. And infection may exist before but usually occurs after extraction due to the error of aseptic technique, for example, or sequestrated bone or residual nerve root or a non-curated cyst. Inspect and clean the socket under local anesthetic and prescribe antibiotic for 6 to 8 days with or without an anti-inflammatory medications. That's all for today. I hope it was interesting. Today's lecture was interesting. See you in a week, next Wednesday. And this time, I hope you'll have internet and you'll have your lecture in time. Thank you for your attention and goodbye. Я закрыла, но там мне ничего не высветилось. Я закрыла просто презентацию, не закрыла на крестик.